I'd like to welcome you to the Retain It webinar series on solutions for achieving surgical and restorative success in the edentulous mandible. It is being presented by Dr. Matthew Hallis. He's the founder owner at Bay Lake Center for Complex Dentistry. And with that, it is my pleasure to introduce Dennis Urban, VP of Education and Training, and also Patrick Hayden, MED. He's a Senior Director of Sales at Sterngold. Patrick, would you like to say a few words?
Sure. Thank you so much, Jessica. Want to thank DSG. Thank you, Dennis and Jessica and everyone at DSG for co-sponsoring this this event. Tonight we've been working with Dr. Hallis for years, and I've seen this course done a couple times, and it's just it's a great 5-part series, and we really appreciate Dr. Hallis you doing this, and we hope all the attendees really find some value with this and being able to really learn some good tips and tricks on improving your clinical outcomes for implant retained overdentures. So thank you very much, DSG, and of course thank you very much, Dr. Hallis.
All right, well, thank you, Patrick and Jessica, and welcome everyone. My name is Dennis Urban, CDT, and I'm the Vice President of Education and Training for DSG. And tonight we're excited to welcome back Dr. Hallis for this part 2 of the Retain It series. Last week, Dr. Hallis covered diagnosis and treatment planning, medical history and review, and treatment options for the edentulous or soon-to-be edentulous patient. And there was a ton of pertinent information. So Dr. Hallis has lectured on dental implant planning, placement, and restoration protocols and procedures throughout North America. And tonight, on part 2, Dr. Hallis will be continuing with in-depth information on one of the hottest topics in dentistry today, and diving deeper into the surgical and restorative aspects of implant overdenture therapy. With that, I want to thank all of you for attending tonight, and thank you to Dr. Hallis, and welcome.
Perfect. Thank you for the intros. I'm going to assume most people were here last part, so I'll keep the intro brief on who I am. But for those that weren't here, we'll just quickly run through where my history is, how I am here, and what do we do. So with that said, I grew up on the East Coast. I went to Tufts Dental School. From Tufts, I went to UIC. I went there partly because they allowed us to place implants as well as restore them. It was unique training, and that's kind of how we have our practice here. From the East Coast, then to Chicago and the Midwest, I somehow ended up at Bay Lake Center for Complex Dentistry, partly because of our passion for fishing. I met my wife at the office that I practiced at in Chicago. We have a big passion for fishing. I travel around the country fly fishing. And there's not many prosthodontists that fly fish with their wives. And that is how I ended up meeting my future partner. Ended up joining the practice, buying into the practice, and we expanded it. We have a lot of windshield time. We have 3 locations. Our main office is based out of Green Bay, and then we have 2 satellites in the Upper Peninsula. We have a practice that focuses on train wrecks and true pros cases. There's not a day that goes by in our office that we're not doing a implant reconstruction of some sort. And I truly think when you look at the day-to-day practice, implants are really a game changer. And when you think about this statement, it really holds true. If you're not providing implant treatment, you're not providing a standard of care. Gordon Christensen said that, and I truly believe that. There's really not a case that we cannot not utilize an implant in order to enhance the outcome. What's important? I speak for several companies. I'm paid to lecture, but I'm not paid to use the products. Okay. Every product I use in my office is what I show in these lectures. So today, as we go through it, it is what I do in my office, and I will go through all of that. Okay. Normally, prior to COVID, I usually forced everybody to see our vacations. COVID kind of put a damper on that last year. Luckily, things are returning back to normal, so I'm kind of excited about that for this upcoming year. With that, as Dennis said, today we're going to focus on the second part of Retain It, which was a 5-part instructional course that'll combine multiple surgical and prosthodontic procedures to help enhance the participants' knowledge in surgical and restorative aspects of implant overdenture therapy. With that, we're going to be in part 2. Part 1 focused on the diagnosis and treatment planning. You can't do surgery without a plan. Can't stress that enough. You won't be able to restore the case without a plan. Today, we're going to be skipping the diagnosis, right? We already covered that. We're going to end up identifying cases for implant overdenture therapy. We're going to look at the surgical protocols for placing implants in the mandible. We're going to talk about post-op, and then we're going to review some complications that can occur. If you remember last lecture, I said, if you don't have complications, you're not doing the procedure or you're lying. From there, the next 3 parts, okay, as I had mentioned before, we're going to talk about enhancement of overdenture therapy utilizing the mini dental implants. That's a big game changer for us in our practice, because the hardest transition is that period of the 4 to 7 months when that patient is healing and we are going from a dentate patient to an edentulous patient with a constantly changing ridge as it heals down, and the patient has a movable denture and is unhappy. Okay? After that, we're going to talk about how to restore these implants that we place, and we're going to talk about attachment design and selection and what protocols do we use. And then lastly, we're going to talk about journey to implant placement in your practice. One thing that I was just realizing this past weekend, I've been doing a bunch of CE this year, kind of with our travel reduced. I kind of been traveling to actually do some CE for my education. And one of the big things that I realized after talking to one of my friends that went with me is when we got back from that course, he didn't make any adjustments to integrate what he just learned. If you kind of have an interest in learning implants, you have to dedicate and really choose and effectively say, I'm going to do this. If you don't and you let it go a week, 2 weeks, you won't do the technique that you're trying to integrate. So that becomes really important. We're going to talk about that. Questions, as Jessica said, I'm going to focus on answering the questions at the end of the lecture today. We're going to keep this lecture to an hour. I don't really have much to do tonight, but I would like to get home at a reasonable hour. So any questions at the end of the lecture, we will answer. If there's something pressing, Dennis is monitoring and he'll chime in. So with that, we're going to talk about surgical placement, okay? Understanding the implant systems for your office, okay? I like this. I did not realize a lower denture would move around this much. This patient was previously seen at our office for examination and consultation appointments, but did not proceed with the treatment at that time. I can't stress that enough. Even if a patient does not accept treatment with us, we are always respectful. We treat that patient well. We let them know if they have any problems, please contact us at any time. As I said, my practice is a fee-for-service practice. I don't participate in any insurance plans, and our fees are set higher. Okay, so sometimes it is a shocker to patients. They might get a second opinion. They might proceed with somebody else. And occasionally, patients will come back if you treat them correctly. With that said, dental history, extractions completed 6 weeks ago with insertion of maxillary mandibular incomplete dentures by another office. Patient wants to review treatment options previously presented. So in our office, okay, and this is something we're going to talk about in series 5, okay, I use a primary implant system of Nobel Biocare, and then I have an alternate system of Sterngold, and I do this for finances and offering patients options, okay? There's premium products, and then there's prices that are out of value. So we have to kind of assess what the demographics are in our office. Today, we're going to focus on the technique of placing, and I'm going to circle back how I select them. But today, we're going to focus on placing a Sterngold type implant. Okay. With that said, the denture examination. Okay. As we reviewed, we talked about the patient's chief complaint, critical. If you don't address the patient's chief complaint by the end of the therapy, the case is going to be a failure. After that, we got to remember the anatomy. Where's the mental foramen? How much bone height do we have? How much bone height do we need for an implant placement? How much bone width do we have, right? Where is the primary loading surfaces, the retromolar pad, the buccal shelf? Okay? After that, we're going to talk about what is the standard of care for radiographs and what is needed to place an implant. After that, we're going to review some of the prosthetic space analysis, biomechanics, and optimum number of implants, and then attachment design, options, and applications. So these are all things we have to apply. So here's the patient biting. Dentures are a little shifted. That's probably just from swelling. They line up outside the mouth. Overall, not bad. Little midline discrepancy, but we can work with this. Space is appropriate. Function is appropriate. Patient's happy. Right? With the minor correction of the aesthetics, I'm okay with that. Borders are decent, not too overextended. All acceptable for considering what the patient went through with immediate extractions, insertion. But now she is not happy because the dentures are moving. Now, this is something that is important. I do stress to a patient that the hardest time is that 6 to 8 weeks from when they transition from a failing dentition to a temporary denture. They're big, they're bulky, they got a soft liner, they have basically a plastic hockey puck in their mouth. They have to be patient, but we have to assess, can we improve this with a properly border molded denture that's thin, appropriate borders, or will implants enhance this? And in my opinion, implant enhancement is a game changer for the mandible. So we look at a ridge, we have healing extraction sockets, relatively parallel ridges, good interocclusal space, right? Good broad ridges, some undercuts that we should probably address at the time of the second surgery, coming from the molar to the premolar to the canine region. But overall, nice wide ridge, good residual ridge height, will have good lateral stability. So we reviewed last time where I primarily put the implants, paired lateral incisor position. You know, we want to get the implants as anterior as possible to prevent that seesaw rocking. When we're too posterior in that premolar region, we're going to have a rock on our denture. Remember, the arch forms do affect the retention and stability of your implant system. A U shape can end up putting a line placement where a V shape moves those implants anterior. Okay, so let's look at our arch form. Where are we going to place these two implants? At the lateral incisor position. There does appear to be a little bit of uneven healing of that tissue, maybe a little inflammation at that number 27 location, but we'll address that after we evaluate our CT scan. Good floor of the mouth depth, right? So first question, what is the necessary radiographs for standard of care in implant dentistry? As of today, it's still a PA and a PAN, okay? However, in our office, okay, and what do we have available? Okay, depends on which office we're at. Two of our locations, we have CT scanners. One, we have a PAN. Okay, so it depends on what we're doing where. If I'm in the location that has a PAN, I use that as a screening. Okay, and what am I looking for? Mental foramen position, height of the residual ridge. Okay, mental foramen, we have to remember, can vary quite a much. Right? We also have to think about the loop dimension and where it is. You know, if we're going to be in the lateral incisor position, the mental foramen is really not typically that much of a concern. But if we're taking out teeth, we're doing a veloplasty, we're going to be placing implants, I want to know where that foramen is. And I want to know my anatomy. So for our office, pretty much every patient that I place, I take a CT scan. I have it available to me, so we use it. Okay? I typically don't do surgery in the location that has the PAN only. We use that as a meeting and screening office. My other two offices have the CT scanners, which we pretty much use as our primary locations. Most of our surgical equipment is there. I do have other stuff in that office, but in general, I kind of tailor it to that. There's only so much you can stock in offices. With that said, what am I looking for? I'm looking for the height and the width, and I'm looking to make any decisions ahead of time. I'm trying to assess, are the buccal plates thick? Do they have dense cancellous bone? Does it look wispy? Are there unusual undercuts? Where is that foramen position? Is the foramen positioned on the ridge? Why do I want to know that? Because I'm going to be laying incisions and flaps, and I need to know where my incision has to be placed. How much height do we have? Plan to use for this case. So, second question. What are the minimum bone height and width requirements for implant placement when planning a 2-implant mandibular overdenture? So what do I typically want to place for an implant? Do I want to place a 3-5-10? Do I want to place a 4-3-15, 4-3-14? Do I want to place a 20 millimeter implant? How big, how wide of an implant do I want, right? So in general, what the textbook tells you is you need a minimum height of 10 millimeters, minimum width of 5 millimeters. That gives us a quite small implant if you think about how much bone we need around an implant. So in general, for me, I want to get 4-3, 10 millimeter implants in there. I want good, stable implants that are going to be able to withstand force. If I can place a 12 or a 14, will I? 100%. So with that said, when you're first starting to look at cases, you want to find a case that has good wide width, okay? You want a mandible 10 millimeters of width, maybe 20 millimeters of height. You don't want to put yourself under stress when you're first doing your first few cases and you're trying to align teeth. But what's more important is the bone sets the tone, right? With that statement, you need to put the implants in the confines of the denture, like we talked about with the space requirements. We can't be too lingual. We can't be too buccal. We got to have enough height. We got to have enough space to fit all of that hardware. So just because we can place the implant, we still have to make sure it falls in the confines of our denture that we plan to restore. Okay, so when we look at this, here's that case. Recent extractions healing, okay? Good height, good width, decent buccal plates, right? But we have extraction sockets. That's not a concern because we can end up going down here and doing a veoplasty, lower that down, increase our prosthetic space. We have plenty of position for implants. We have a low foramen position. So in this case, life is good. One other thing to note is when you look at the buccal plate, the lingual plate, you see a good defined clear white line. That usually means we have good dense plates. But then looking into that CT scan, we have kind of more defined cancellous bone. This is going to be a harder type protocol, so it's going to start helping me make decisions when I'm looking at the patient and deciding what drilling protocol am I going to use. Am I going to use a medium bone? Am I going to use a dense bone? Am I going to use a cortical drill? Do I need a screw tap in this case? Okay. When you see a lot of black, okay, or space with black, that means they're going to be in softer bone profiles. Okay? Typically, we see that in older patients. Okay? As they age, we get more cancellous bone, so things to keep in mind. Okay? Looking at some more CT scan cross sections. So overall, this is a great case to start with. Now, important, okay? Depending on what kind of malpractice insurance you have and all of that stuff, we need a consent form. The patient should be informed at the time of the initial visit about the diagnosis, prognosis, and treatment options with the expected outcomes. We have to talk about possible nerve damage, paresthesia, rejection of the implant, replacement plan if that implant does fail. What are the options? How is it going to change the time? That's something clearly important to explain to a patient, because if I have an implant failure, that's going to add 4 to 8 months to that treatment. If I have to remove that implant, let it heal, come back and place it, that is a critical thing to explain to a patient, because now their treatment has got pushed out 10, 11, 12 months, depending on then how long it takes you to restore this case. And then the big one, I always explain to patients, we're going to make incisions. We're going to be drilling holes. We're going to be flapping tissue. There is going to be some post-op pain. There is going to be swelling. And you have to be realistic about what that patient is going to experience. Okay? All of our medications are standard. I typically give 800 milligrams of ibuprofen or Tylenol, or a combination of ibuprofen, Advil, or Tylenol. I do give them a loading dose of amoxicillin or clindamycin, depending if they're allergic. If they're allergic to penicillins, they get clindamycin. If they're not, they get amoxicillin. We do 2 1-minute chlorhexidine rinses. Okay, sedation. If this is a 6 to 8 extraction case, or if it's a healed ridge and I'm placing the implants, I avoid sedation unless they are very nervous. Now, are there patients that are nervous, truly fearful of the dentist, worried that it's, and I think it's going to take more time. The patient is not going to carry through that. We will sedate that patient every day of the week. But in general, I do a lot of these under just local anesthetic. Sedation really slows me down. Okay, anesthetic. Okay. It depends. If I am doing a lot of extractions, if we're doing a big avioplasty, I will do bilateral block anesthesia with mental foramen blocks and then infiltration. I use lidocaine. I will rarely ever use septicaine in the mandible. I don't find I need it. I do overlay everything with Marcaine so they're comfortable. I use the appropriate length needles based on what I'm doing. Your surgical kit, okay, for implant dentistry is the same whether I'm doing a single implant all the way up to multiple implants. If you do extractions in your office, you have the majority of the instruments. The only thing that I do add and change is when I am doing a avioplasty, we have periosteal elevators specifically for avioplasty. I do not want my elevators getting nicked up that I use for tissue reflection. So those are the only things that I modify on my kits. Okay. So today we are going to be focusing on the true implant system from Sterngold. We're going to go through the implant placement, on how the technique of drilling, deciding on bone density, deciding when you need the tap. It's pretty much standard across all implants. What we're going to talk about is when you're assessing a system and deciding on a surgical kit, okay? We're going to use this as an example. How do you decide on choosing a surgical kit. What are you looking for? You know, when I look at a kit, I'm looking for an initial pilot drill, a way to make a purchase point, okay? Then I'm looking at the pilot drill. Do they have clear markings? And then what is the flow of this system? Are there clear jumps between your drills? Is there an adaptation? If I drill in and I decide I'm in soft bone protocol, can I place that implant with minimal drilling? If I'm in dense bone and I try to place that implant and it doesn't even go halfway, what are my alternatives? Is there a cortical drill available? Is there a bone tap available? In the mandible, because of the density of the bone and non-extraction sockets in the anterior, I am almost always bone tapping. Cortical drill varies, okay? And we'll talk about that. Then what kind of implant placement connections do I have? Do I have a hand driver? Can I place this with a motor? So we're going to talk about that as we go through this case. So the first thing I always get from everybody, okay, and this is a big decision, is do I flap or do I do the procedure flapless? What is my deciding factor, okay? When it is necessary to observe the underlying alveolar bone and adjacent anatomical structures, it's necessary to flap when we're placing bone and or connective tissue grafts. Implant placement without a CT scan. So I don't really do an implant placement without a CT scan. As I said, I have it available. I see no reason not to take one, okay? I will tell you in my office, I do not do flapless surgery. Okay? It is very, very rare for me to do flapless surgery. Do I modify my incisions? 100%. Do I use CT guided surgical guides in my office? Yes, but it is very rare for me to do a flapless surgical implant placement. I want to assess the type of bone. I want to assess the quality. I want to make sure my platforms are where I need. It is rare that I don't need to adjust some contours or remove undercuts and do some pre-prosthetic surgery. So for me, I want to see direct clinical access to that bone. Okay? With that said, we have to decide on the incision design. Okay, we have to look at where is the attached and unattached tissue. That is critical. We have to be able to suture through attached tissue. Also, remember what I said, it is clinically recommended to have attached tissue around our abutments. I think that's critical for locators that are snapping in and out and you have dentures rubbing on it. You need to decide how and where we're going to gain attached tissue and keratinized tissue. Do we need to think about pre-prosthetic surgery or can I modify my incisions to increase? Okay. After that, we have to think about the inclination of the lingual and labial cortical plates. This is critical. Okay. When we have an edentulous mandible that has been like that for quite a long time, we have to palpate manually and find, is there a slope? And one of the things I assess on that CT scan is what is the underlying anatomy. The second thing I do after I've numbed that patient up, before I make any incisions, okay, I do this for singles, multiples, all the way to the fully dentate edentulous patients, is I use a perioprobe and I go along where I plan to put my incisions. And all I'm doing is probing for constant stops. If my perioprobe slides somewhere, your surgical blade is going to slide, okay? So I'm outlining my incision design where I'm going to be. I'm making sure I have enough keratinized tissue on both sides so that I can facilitate suture. If I don't, I got to think about modification of my incision. So in this patient, we have a broad, wide ridge, okay? In this case, knowing the CT scan had multiple extraction sockets under it, the flap reflection, we're going to have to think about how to accommodate this. I told you we're going to be doing some ophiloplasty, but plane that bone down. We're going to have to get all that keratinized, collagenous tissue out of there that's healing, okay? Where am I going to be? I'm going to be dead center in the crest of this ridge. There's good keratinized tissue on both sides. Now, releasing incisions. What do we have to think about and where do we have to think about? Hopefully you can see my mouse. We have to think somewhere over here, there is a mental foramen. Okay? We have a highly vascular area through here, okay, in the anterior mandible. So when we start looking at this, we have to think of an incision design that permits visualization of the alveolar ridge, allowing for alveoloplasty, allowing for alignment of your implants, allowing for direct visualization of what we saw on that CT scan, okay? Any concavities, okay? When we think about vertical releasing incisions, they have to be shallow. They have to be either anterior or posterior to the foramen. It is rare that I need a releasing incision in the mandible. When we think about breaking the keratinized tissue, the tissue just then peels back. All I do is extend my incisions more distal than I need to, and then I can suture. A 10 millimeter incision heals the same as a 15 and a 20. Okay. Care must be taken to identify the foramen and the position, the incision, okay, to either be lingual to the foramen or anterior to its location. You need to palpate it. You need to visualize where it is on the CT scan. We start looking, make our incision, cut the bone down. If you need to extend longer, extend your incision longer, open more tissue. Use a rongeur, a round burr. After that, critical statement with overdentures. In order for individual attachments to provide adequate retention, all the implants need to be placed as parallel as possible. If the implants cannot be placed relatively parallel to each other, then a bar design would be indicated. So how do I verify my parallelism? I use a surgical guide that has a trough that makes sure I'm not too lingual, not too buccal, I'm within line. I have a veoplasty marking, and it's a duplicate of my planned implant denture, okay? Anything in that height, I reduce, okay? I need to have an alveoplasty recommendation or guide. I can't just eyeball it. And anything in that window gets removed with a burr or the rongeur. Then I start looking at the alignment of where I can place the implants. I want to be somewhere anterior in that lateral incisor canine position. The more anterior I can be, the less rocking I'm going to have. I got to think about spacing of our components. From there, now that we have the tissue incised, it's flapped open, we have the alveoplasty completed, we have our positions confirmed, we need to take our surgical kit out. Okay, and we have to think about what sizes we want to place. In this case, we're going to place a 4-3-14. If I have the length and I have the room, I'm placing the bigger of the implants. Okay, that is my protocol in my office. I know a lot of the literature states that there's no difference between a 10 and a 14. Okay, but at the end of the day, we lose a little bone. We take function on these implants. I prefer to have bigger, longer implants in my practice. If I have a choice for when I'm selecting a locator system, I want to put the regular platform implants, the 4s, 4.0s, 4.3 implants. They're a stronger, bigger implant. If we think about how much torque a locator is going to place on those implants, I'd like to stay away from the 3.5s. I'm not saying the 3.5s are not strong implants, but I'm just thinking long term. Our drill protocol, absolutely critical. When you're drilling, you need to have intermittent drilling pressure. We have to know the drilling speed of the implants. In the true kit, they're about 1,200 RPMs. If you drill too high, they're chattering. If you drill too slow, you're putting too much pressure and they're not efficiently cutting. From there, you need depth markings and you got to see them. Are the drills the actual length or the tips longer? Some drill kits, the line is 6, but the drill tip could add 0.6, 0.8, 1.2 millimeters to that length. Okay, so in the anterior mandible, that's not really a big concern because there's no vital anatomy that we have to worry about. But when you're over the mandibular nerve by the sinus and we're trying not to penetrate the floor, that becomes critical. Then we need irrigation. I use external irrigation, whether it's on the drill or my assistant is spraying. Okay. We have to minimize and control heat generation. If you take that burr, step on the pedal as fast as you can and you bury it into the bone, you're going to cause necrosis. Okay. The heat generation is incredibly hot. And if you grab that drill, it will be warm. So we need cooling fluid. We need to think about the bone quality and think about how many jumps between drills we have. How deep are we drilling? Okay. Do we have sharp drills? I personally change every one of my drills out of my kit every 5 times I use them. We track our kits, we label them, we record how many times we use that drill during the procedure. Bone contact, you need intermittent drilling. The deeper and more pressure and speed controls heat as well. Okay, so I don't use internal irrigation. I don't think there's good control on it. I don't like it in the drills. It can clog. So we use external irrigation. Okay. Some people have a debate between saline and sterile water. We use saline in our office. When you have a drill extender, this is critical to remember. You have to think about increasing your irrigation to the drills because of the length now that's included. Flapless is another reason why I avoid flapless is the amount of irrigation getting to that drill is significantly reduced, especially when you're drilling through a guide. Okay. We have to remember we have to manage the bone contact heat generation. Okay, temperature should not rise beyond 47 degrees. Okay, we have to drill for 1 to 2 seconds, then move the drill vertically without stopping, okay, allowing the irrigation to fill that site. So you drill down, lift, drill down, lift. As you get deeper, you need to fully lift out of that osteotomy to allow the irrigation to get into that osteotomy and cool the drill. Okay, so in this kit, the first drill we're going to use is the Lance drill. This is a game changer of a drill, in my opinion. I am a big fan of these. I do not use the round burst. I like these because they are incredibly sharp and they can penetrate the cortical bone. I use them in immediates. It allows me to gain purchase points on walls of an extracted tooth. In the mandible, if we're in a edentulous site that I did not do a veloplasty and have cancellous bone, I am able to place the drill, align because of that sharp tip that you can see there. It has a purchase point. I can verify with my surgical guide and then I can drill. Now, when I have depth there, what's critical is you need to get to about this position. You need to have about 5 millimeters of this lance burr buried, okay, in the bone in order to start your 2 millimeter twist, okay? Irrigation throughout all my drills is the same. It is turned up. I make sure that we're not waterboarding the patient and that my assistant can keep up, but we have copious amounts of irrigation. Okay. After we've started that drill, we're going to jump to our 2 millimeter twist drill. Okay. Now, I have a rule when I'm placing implants, okay, whether I'm doing a single to an edentulous. I always drill to 7 millimeters, and then I take either a pilot x-ray or I place a pilot pin and verify my position within the surgical guide. In this case, I'm not taking a pilot x-ray because I'm not looking for adjacent teeth. I'm not looking for sinus floors. What I do here is I have a pilot pin and I verify my position, okay, to both buccal lingual as well as within the confines of that denture that I'm in the most anterior position, okay, that I was planning. From there, you have to know the depth markings of the drills you're using. I use 2 different kits. The drill depths are different. In this kit, it's 6, 8, 10, 12, and 14. Okay? So I typically split the difference between 6 and 8. Why do I drill the 7 if I'm placing a 10 or a 14 millimeter drill? If I happen to drill crooked, I still have plenty of room to correct that misangulation. If you drill your pilot hole all the way to depth and you realize you're at a 13-degree misangulation, that is quite harder to correct that misangulation. It's going to happen. You have a patient flapped open, laying back, no real references. You're going to be off from time to time. The key is knowing how to correct it and using parallel pins. So I always place my first osteotomy, 7 to 10 millimeters. Make sure, okay, I'm happy, parallel, okay, where I want to be in that surgical guide. I then place it. Okay, make sure it's secured with floss in the mouth. You don't want to be the guy that has a patient swallow one of these pins. After that, I drill the second hole. I almost always drill the number 27, 26 area first, me being right-handed and where I stand looking at the patient. I typically stand in front of the patient drilling in this position, and then I verify from up top by standing behind the patient that I'm within the confines. And again, that is why I drill the 7 millimeters. So parallel pins in place. These are drilled 2-7. We're going to look at, make sure we're at our position, buccal lingual, as well as then in the most anterior position that I want to achieve. Make sure they're parallel. Any miscorrection, we're going to align and correct. In this case, when I look at it, number 26 is a little to the left. Number 23 is a little to the right. So I will change that up. Okay. But again, make sure they're secured with floss. I can't stress that one enough. All right. After you've verified your position, you know the corrections you need, you have to drill to the planned depth. This is the #1 mistake I see with new surgeons, okay? For placing a 10, they drill the 9. You have to drill to the top of that line. Where you drill is where your implant will end, okay? Where you drill is where your implant will end. I constantly see doctors drill slightly shallow and then have an implant that doesn't fully seat if they follow the proper drill protocol for the bone density. Okay, #1 mistake is drilling short. So we have to drill to the planned depth. Okay, after that, A is your 3-0 drill. This is your final drill for a 3-5 true implant. But I said we're going to place a 4-3, so we are going to have another one. So we drill this one to the planned depth, okay? I usually drill 1 implant site to full depth, okay, and size, leaving the parallel pin in the other one. So in this case, I would drill number 26 to full depth and size, leaving the parallel pin for number 23 in place. That gives me a reference as I'm drilling. Then I don't, once you're out of the 2mm twist, you don't have an ability to put a parallel pin in, and I only have 1 set of drills. So then you're not going to be able to put a drill in that osteotomy and then drill. So for me, I drill 1 implant osteotomy to completion. Okay. In this case, we're going to use the 3.8 drill. Okay. We're going to assume this is a medium density bone. Okay. This is your final drill for the 4.3 true implant. Again, you drill the depth. So in this case, it's going to be the 14mm, copious irrigation, 1200 RPM speed, intermittent drilling pressure. Then we got to have some type of carrying system to bring the implant out of the package and into the mouth, right? It's got to be connected to either a handpiece, a hand driver of some sort. We have to understand how the package opens, okay? With a conical connection implant, you need to make sure the hex driver, okay, or the implant carrier here is fully inserted. If it is not fully seated, you're going to lift this out and drop the implant on the floor in the patient's mouth. So you have to make sure the driver engages the hex inside the implant. Absolutely critical. Okay. After that, we're going to set our motor to some type of insertion torque. Personally, I prefer to place the implant using the implant motor. It allows me to keep the same parallelism that I drilled that implant in. It allows me good control. The implant motors we use are torque controlled with a really accurate graph that I do have calibrated every year. I'm a big fan of doing it that way. My partner from time to time uses the hand driver. This is personal preference, okay? For us, you need a torque for the implant placement refers to the rotational energy that must be used to overcome the relative resistance of the bone. So I set our implant motors at 45, okay? I believe the sweet spot for most implants is 35 to 50, okay? I use 45 because I do not want to compress this bone too hard. This is a parallel walled implant, okay, with relatively aggressive threads. The final drill in that case right there was a 3.8mm drill with a 4.3 jump. So that is a fairly big jump to allow you to get stability in immediate sites. In dense bone, type 1, type 2, you are going to need to end up going to a slightly higher drilling procedure in order to accommodate that. Now, this is important because I see a lot of people that don't use a torque wrench correctly. And if you bypass that ball, grab that handle, you can easily generate well over 200 to 300 newtons. Some ratchets can go up to 400. Okay, these implants are strong, but they cannot survive 400 or 500 newtons of torque. Okay, bone won't survive that. You'll get osteonecrosis. Okay, I'm a big believer. These implants should not go over 55. Okay, as I said, I typically stay somewhere in the 45 Newton range. 55 is okay in some cases, but I'd rather drill more. Okay, I'd rather bone tap. So what happens if the implant will not fully seat? So in this case, you have it set to 45 newtons, goes to depth, you are done. Now, half that implant, the micro threads are showing. A good quarter of that implant is not seated. I am going to back it out. Okay. I am going to make sure the implant is placed back in the titanium sleeve. We're not going to drop it on the floor or drop it on the tray. Then we're going to modify the implant site. This is your first few cases. Check your depth. Get your depth implant probe out and make sure your osteotomy was 14 millimeters. Okay? Or if you drilled to 10, make sure it's 10. From there, if you know your depth is correct, you need to modify for the bone type and use the dense bone protocol. Okay, so when we think about it, typically the anterior mandible is going to be considered denser bone, better quality. Typically type 1 or 2. It's rare that we have type 3 or 4. Okay, so in the anterior mandible, I almost always plan to drill in dense bone. when I take my 2mm twist, and if I go through with mild intermittent pressure and it's just cutting through like butter, I know I'm in soft bone. If I'm going intermittently up, back, and I'm feeling resistance as I'm drilling, I know I'm in type 1 or 2, and I'm almost always going to bone tap. Okay. So what are your options, okay, for a dense bone drilling protocol? First is going to be a titanium bone tap. It is going to thread the osteotomy for you. We're going to use a dense bone drill, okay? That will be an enlarged drill going over the 3.8mm drill, okay? And then a cortical drill for enlarging the crest. So dense bone protocol. Our final drill was the 3.8 for the 4.3. Your final drill will be a 4.05mm drill. So it's decreasing the wall to implant size. So instead of having a 3.8 to 4.3 or a 0.5mm jump, now we're going to have less than a 0.3mm jump, taking off pressure as that's going in, allowing for expansion. Okay? So dense bone drill is drilled at the same speed. Okay, you have to take its plan depth. Okay, make sure you use irrigation. From there, okay, if I had half of that implant not seat, I'm going to tap. If you were all the way down to the micro threads, I would try to place that implant. Okay, so we have to kind of start deciding, and this comes from clinical experience. Can I place that implant or should I? It's a heck of a lot easier to go from a smaller hole to a larger hole than a larger to a smaller. And what I tell patients is I'm going to make an estimation here. I think I've tried drilling your bone to the density that clinically is experiencing. We're going to try to place the implant. If I can't, I'm going to back it out and we're going to further enlarge the hole. We might do this once or twice as we decide on modifying it because it's easier to go from smaller to larger than larger to smaller. Okay. The bone taps create internal threads in the osteotomy, but write this down, circle it, take a picture. Do not drill at the speed of your drills. You either change it to 30 RPMs or Newton centimeters. Okay, I usually use Newton centimeters. I use irrigation. I set it at 45. I set the reverse at 50 so I don't have any reversal torque to overcome. Okay, what is critical, and I can't stress this enough, with the bone taps, you have to make sure you do not angle your handpiece because you can modify that osteotomy and now you won't be parallel. Okay. You also have to decide on if you're going to do a full tap or a half tap, and that goes based back on how much of that implant seated. Again, if half that implant seated, I'm going to do a full tap, take that to the depth of the osteotomy, and then you hit reverse. But I cannot stress this enough. You need to be in Newton centimeters. Now, a cortical drill, okay, I don't use these too often. I usually use these when I see how thick the cortical plate is. And I look at the CT scan. If that cortical plate is 2-3 millimeters thick, I will use that. And what it's doing is just modifying the first 2 to 3 millimeters of the osteotomy to release some pressure of the cortical bone, which has almost zero elasticity. Okay. This is at about 200 to 600 RPMs. These drills, you got to be careful that you don't misangle. It's a short drill. It is only meant to modify the superior portion of the osteotomy. Make sure you use irrigation. Okay. Again, there was a mountless delivery. You put it back in the titanium sleeve. Make sure you engage that driver and you place your implants to depth. Okay. Now, you have to decide on one stage versus two. For overdentures, it's always two-stage surgeries for me. And what that means is I place a cover screw and I suture. I do not want a soft liner loading those healing abutments and hardening and moving around that denture and just constantly causing micromotion to your implants. So for us, I do a full flap. I don't do flapless, as I said. We place the implant, place a cover screw, and then I suture. Okay. You hand tighten the cover screws only. In the True kit, it uses a 0.048 hex driver. Okay. And then we need suturing. This is where you need to spend time practicing. Okay. If you have a suturing technique that is quick, efficient, you will manage your time well. I see more doctors that come to our office doing a mentorship struggle with suturing. get a banana, take home some 15 blades and sutures and practice at home. Okay. Short incisions, single, 2 teeth are managed with single interrupted sutures. But long incisions, you need to manage with a continuous interlocking suture supplemented by a few continuous interlocking sutures, okay? The continuous interlocking suture is one of my go-to sutures for the mandibular overdenture, okay? It provides uniform distribution of tension across the length of the suture and a good wound margin, provides rapid closure of a long incision with a single knot placed at the beginning and a single knot placed at the end. 2 great books, okay? I really like the suturing techniques in oral surgery. I practiced and I spent a lot of time suturing bananas at my house. If you have a local butcher, yes, you can get a pig jaw. You just need to practice. I like the bananas because they tear. They're easy. They're cheap. They're easy to get. I don't have to go to a butcher. Okay? With the single interrupted suture, you're going to complete a single knot first, and then you're going to bring that needle down, taking between 3 and 4 millimeter parallel bites with a locking potion. Make sure that it pulls down nice, tight, and uniform, okay? We're going to pass that needle through the suture. We're going to tie it off at the end, okay? Now, in the mandible, if I have from second molar to second molar, I will put in 3 to 6 single interrupted sutures to get all of the tissue approximated. I will then do 2 continuous interlocking sutures, midline the posterior, midline the posterior. In this case, I did 3 single interrupteds at kind of premolar, central area, premolar, and then 1 continuous interlocking suture. Good uniform spacing of your sutures, not too tight, not too loose. Okay, you want to have good approximation of your margin, good clean reapproximation so things heal well. Okay, for a long time, I was using Vicryl. Then I switched to chromic. Then I've switched back to polypropylene. Okay. Now I'm back to chromic and Vicryl. It depends on what I'm doing on the patient. Problem with Vicryl is it heals with a lot of inflammation, in my opinion. It ties really well and works and functions really well with continuous interlocking, but it does not resorb out on its own easily. As I showed you, I have a lot of windshield time between my offices. So long distance traveling patients, I will put chromic, typically use 4.0, okay, with an FS2 needle. So summary, we review a CT scan, we make sure we have good width, good height, good density of bone. We are then going to place our implants based on our spacing. We're going to evaluate the patient as we previously talked. We're going to look at the arch form, where the most anterior position that we want to achieve the implant placement. Okay, we're going to evaluate the patient's denture, make a surgical guide of some sort, place the implants. As I said, make sure your parallel pins are parallel at this stage. Drill the 7 millimeters and place them. These are pictures I got off the internet. When your pins are not parallel, your implants will not be parallel. Okay, it doesn't get better. Okay, by closing your eyes. From there, we place the 2 implants, place cover screws, suture the patient, say see you in 2 weeks. Okay, for almost all of my patients, I put them on 875 amoxicillin BID, okay, for 7 days. If they're allergic to penicillin, I switch them to clindamycin, 150 to 300 milligrams. Sometimes I do add flagyl if I did significant extractions or I think there's going to be some post-operative healing issues. Okay, medications. It depends on what the patient wants. A lot are managed with Tylenol, Advil, 3 times a day for 3 days, 600 milligrams of ibuprofen, 500 milligrams of Tylenol. If I am going to give something, I usually use Norco 10. Okay, it is rare that I use Percocets. Do I use Tylenol 3? Yes. Chlorhexidine rinses, I don't really do. A lot of people ask me. I've actually switched to a new product. It's Perioscience Gel. If I am worried about bacterial load and inflammation, but I will typically not have them start that for about 3 to 5 days. And then I would have them use it 3 times a day for a week. Okay, this is critical. I tell the patients 48 to 72 hours, you're going to have post-op swelling. Okay, it's going to be worse at 48 to 72 hours. I ask them if they can sleep in an old recliner or 2 pillows, ice as much as you can, keep your head elevated for the next 3 days. Okay, I ask them to only wear the removable devices when needed. If they are really worried about being able to use their temporary denture, I have them sleep with it for 24 hours. Typically, the mandible, I'm not too concerned of. The maxilla is where people want to wear their teeth. We give them written instructions, and we have a 24-hour emergency contact information that they can get hold of me or my partner at any time if they have questions or concerns. In our notes, okay, the length, the location, the lot number, any difficulties encountered during surgery are all recorded. In our office, we keep an implant book, okay, in case anything was ever recalled. We look at it by the year, okay. We are able to assess what implants we placed that year. There's no way we would be able to go through all of our charts and look at which lot numbers we use. So we have a yearly implant book. There's 2 stickers on the package. One goes in their chart, one goes in the implant book with the patient's name, chart number, and then the products that we used, okay. Complications, okay. What do we want to avoid? What do we need? Yes, that is 2 implants. This is not my case. They are stacked on top of each other. So we're going to talk about what do we need, okay? First thing, Mish once said it before, okay? Majority of implant complications can be avoided with thorough planning and evaluation of the patient, assessment of the patient, looking at the ridge anatomy, clear, defined assessment of the CT scan. Plan your surgery ahead of time. Make sure you can do it, okay? After that, we have to kind of look at what type of implant complications can occur. You know, human error, trauma, you know, where is that foramen? Do we incise it, okay? Making sure we assess the patient's medications prior. Are they on a blood thinner like Plavix or something different? Are they on a combination? Do they have a history of bisphosphonates? Then anatomy problems. Where is the mental foramen? Where is the loop? Okay, where was my incision going to be? Then procedure problems. Lack of primary stability is probably one of the biggest ones. We didn't talk about it today, but you need to have a stable implant, okay? Implants need to be inserted in with 15, 20 Newton centimeters so you have good bone contact. Anything under 10 Newtons is a spinner and you're going to get fibrous encapsulation, okay? So with that, we have to think about hemorrhage. When we're doing a veloplasty, is there a accessory artery in there and we have some bleeding? Can we crush it? You know, one of the good things one of my surgical colleagues says is bleeding always stops, but we have to manage it. So typically I can clamp it, okay, or crush it. If it's in the osteotomy, will the osteotomy with the placement of the implant occlude it? So we have to kind of make decisions, okay? Most bleeding will stop with 5 to 10 minutes with constant pressure. If it hasn't, we have to start modifying that. Inferior alveolar nerve injury, okay? The one thing is sometimes I have to reflect out the foramens for these cases when I'm doing bigger cases like an all-on-4. They are going to have some post-op paresthesia. As long as the implants and you were gentle on the nerve, they will not experience it. There's really no reason they should have post-op paresthesia when we're working in the anterior mandible. Lingual nerve becomes critical when we're doing incisions back there for big reflections. If you have multiple extractions and we're reflecting all that tissue and doing a veloplasty, you need to know your anatomy, where that pathway of the lingual nerve comes, okay? Hematomas, I do not see this as a complication. It's part of the procedure. Okay, we open tissue, we took out teeth, we're pulling, we're tugging, we're using periosteal elevators. They're gonna have some hematomas. They're gonna have bruising. If they're fair skin, over 50 on a blood thinner, such as an aspirin, they're going to bruise. I tell patients, you're going to bruise. You're going to have bruising for 5 to 7 days. By day 10, you're going to be fine. Make sure you take your antibiotics as prescribed and ice and keep your head elevated. Okay? I like to use this slide. This is an all-on-4 case that I had to remove multiple teeth, do a veloplasty. And this patient, we had to take out her teeth. When I saw her at day 10, she was smiling and happy, but I walked into the operatory and she said, "We need to talk, mister. Okay? Look at what you did to me." So she had taken pictures for 10 days with her iPad. I never really had a patient do that. And she said, by day 3, I was really swollen, but you had told me this and I didn't call. I said, that's perfect. Okay. If she had a concern, she would have called me. And I tell patients, what are concerns? Okay. So she showed me day 3, day 10. Okay. Really interesting, really important. Okay, she's happy, hematomas are gone, but it's gonna happen. Okay. One of the big things and the most common complication I see with mandibular overdentures is incision line opening. You got to have a good suturing technique. You got to have that tissue reclosed, and you got to manage that temporary denture. It's why I ask patients to stay away from using their denture. They need to be on a soft diet. If they can't cut it with a fork, fish, pasta, rice, you're not eating it. Stay away from sharp breads, cereals, right? Now, if they do open that incision line, you need to gently debride it, okay? Have them rinse with chlorhexidine, or I do use that perioscience, okay? Most of the time, suturing is contraindicated because you're gonna have friable tissue. You have to get it to heal. The problem is you might get some ditching around your implant. It will usually heal and progress uneventful. You have to take away their temporary appliance. They may not like that, but either if they continue to wear it, that tissue will not close, so you take away their temporary appliance, okay? After that, we have to think about how healing progresses in osseointegration over that next 4 months. For us, we typically wait 4 months. If they're diabetic, smoker over 80, 5 to 6 months before I do the stage 2. Stage 2 uncovery is simple, straightforward. I make 2 small incisions over the top of the implant, and I place the appropriate size healing abutment that is going to match up to the attachment system that I am going to use. Okay, I do torque test all of my implants at that time. And after that, we're going to then proceed to the restorations, which we'll talk about at the next lecture next week. Okay, as I said, the 3 books that I recommend for a references, the Color Atlas of Dental Implant Surgery is the picture book of how to do this. This book is harder and harder to find now because he has newer editions. I think the 2nd edition is a fantastic book. I used it 10 years ago in my residency. We still refer to it from time to time. The 2nd book that's a good one is Surgical Complications in Oral Implantology. I like this book. It has good surgery complications, good restorative complications, and how to fix. Okay. With that, we finished part 2. I'm going to stay around, take some questions. I think Dennis is going to read those questions to us.
Yep.
And we'll go from there.
Great. Thank you, Dr. Hallis. What a great presentation and some pertinent information there. A lot of information, you know. So we do have a few questions here. So I'm going to get started with the questions and let's see what we have here. First question is, oops, start my video here. Okay. Many of my older edentulous patients have been or are heavy chronic smokers. Do you have a more in-depth post-op instruction for this type of patient?
Okay, so in the mandible, my clinical experience with implant placement for an overdenture in the mandible is not as critical as the maxilla. Maxilla with a smoker, I believe it's the kiss of death for implants. The mandible, as long as I can get good primary closure, good solid implants, good placement technique, I usually do not have an issue. And by that said, if I can have the patient stop smoking for the day of surgery through the suture removal, it greatly enhances your success and decreases your complication rate. The #1 complication I see with smokers in the mandible is I typically see 2 to 3 threads ditching around the implant at the crest, okay, of that implant. But long term, it seems to be stable and fine once those are integrated. Where it becomes a problem is if you get exposure of that rough surface in the mouth, okay? So on smokers, I tend to place the implant about 1 or 2 millimeters subcrestal, try to get them to stop, okay, smoking the day of surgery for 2 weeks, 2 suture removal, and then after that, I let them heal, and it seems not to be an issue, okay? But in the maxilla, all bets are off. I really do not do unsplinted implants on a smoker in the maxilla.
Great. Thank you, Dr. Hallis. Also, that was from Dr. Ford. Dr. Ford said it was an awesome presentation. He really enjoyed it. So thank you, Doctor. Appreciate it. So, okay, so this is from David Langston. What type of technique do you use to grow burn vertically? I understand it's difficult. What is your experience with that? What is your protocol for a spinner implant?
Okay, so the vertical bone growth, I'm not really going to get into that because that doesn't really apply to this, and that is a complex, in-depth talk. My opinion, vertical bone growth is incredibly unpredictable. Okay? Some of the best surgeons I know, it is unpredictable. Okay? I can grow bone horizontally, very predictable. Growing bone vertically, when you have no walls, no blood supply, is incredibly unpredictable. So in that's a whole different technique. I use pink porcelain the majority of our cases to correct that. A spinner implant, okay, that's a more pertinent problem, okay, and that happens twofold, okay. One of the big problems dentists do is they wobble when they're first drilling and they get nervous, and now they create an oblong osteotomy instead of having a parallel walled osteotomy. The beauty of the true implant system is you do have a 3.8 final drill for the 4.3. So it gives you a little bit of a leeway as you're learning the drill, okay? So your jump between the final drill and your implant and your bone contact is much more dense, okay? So that's something that is a good thing. Now, you have a spinner, you have to make a decision, okay? Can I place a wider implant in that osteotomy? So can I plan to go from a 4.0 to a 5.0 or a 3.5 to a 4.3? Typically in the mandibles, I can. Okay, it's gonna happen. Okay, it's gonna happen. One of my best friends placed an implant at 1200 Newton, 1200 RPM torque, spun that down into the osteotomy and called me in a panic. Luckily, we're close to each other. And I told him, just remove that implant, clean the site up, try to put a bigger implant in, and it'll usually be okay. Now, if you're on the other side of that fence and you can't place a bigger implant, you got to that site and come back, okay? In the anterior mandible, if that happened to me, I probably would modify my position or I would add a third implant. I don't really want to come back at 4 months. So that would be my take on that.
Great. Thank you, Dr. Hallis. Those some great questions there also. This is from Natalie. Can you use a tissue punch for stage 2?
You can, but unfortunately, you're going to remove a tremendous amount of keratinized tissue. So if you look back for a quick second, if you use the tissue punch, okay, your tissue punch is going to be somewhere on this border, and you're going to remove 3/4 of that. I personally would not do that. I would numb the patient with local infiltration. I would get a perio probe, feel where the cover screw is. I take a 15 blade. As you see, those incisions are no longer than 5 millimeters. And I expose the implant. Now, the only time I flap an implant is if I see crestal bone loss around an implant or something that is concerning me. I will then do a full thickness flap with a full incision. And I would probably go another 10 millimeters on both sides of this.
Great, thank you. Now we have an anonymous attendee here. For how long do you advise patients to not wear their dentures while waiting for osseointegration?
So that's a patient by patient kind of thing. So some patients will not leave your office if you tell them not to wear teeth, right? Other patients could care less. Previously, this mask mandate was great because patients did not care. So that was a huge help. Okay, so with that, if they can leave their denture, temporary, partial, whatever it is, as a removable device out for the next 7 to 10 days while we get primary closure, fantastic. If they want to wear it, light pressure, take it out as much as you can. The more you leave it out, the better, okay? If they are worried about wearing it, okay, and being able to wear it the next day in front of their husband, wife, whatever, I do tell them to sleep with it for 24 hours. Take it out in the morning, okay, rinse, put it back in. It's going to be painful taking it in and out, but that'll help mitigate some of the swelling so they can wear it.
Okay, great. Yeah, I had a question also for Dr. Hallis on these dentures, you know, with that waiting period or right after surgery. I think you mentioned you're not using any kind of soft liner, right?
I am using a soft liner.
Oh, you are. Okay, you are. Okay, I just wanted to make sure.
So there's 2 types of liners that we would reline the denture with. First is the Co-Comfort, which is the white one.
Right.
I am not a huge fan of that one. It doesn't stick to the denture well. It tends to lose its moisture and harden 3 to 5 days. I use a lot of Co-Soft, okay?
Yeah.
And the main thing that I see is one of the biggest problem is overextended borders that cause sore spots and digging in. So I do cut the borders back, and all borders are done in Co-Soft. I also like the Co-Soft because it's pink. Denture patients are notorious for counting how many teeth you put on their denture, and then why is my denture white, right? So if I can use like materials, we use a lot of co-soft in our practice. My partner uses Linol. He likes that one. That's personal preference, but we use a lot of co-soft.
Great. Yeah. postop is a great product. I used to work for that company also.
Yeah.
But yeah, some great products. And there's a lot of choices of soft liners on the market. But yeah, thanks for clarifying that, doctor. This is from Dr. Koss. Can you put a healing abutment on the implant straight away?
You can, but you run the risk of causing a loading of that because you have to relieve the denture, which is going to rotate all over that mandibular jaw. So as I said, I don't do single stage surgeries for overdentures. Single teeth, absolutely.
Great, thank you. Do we have any more questions?
There's one more in the chat box. I'm not sure if you see it, Dennis. It's
Let's
from
see.
Dr. Carrillo Medina. It starts with after Alvelio.
Okay, let me pull it up here. Okay. Alrighty. I don't see anything in the chat box here. Okay.
I'll
read it?
repost
Yeah,
it
okay.
to you because
Yeah.
I don't know this first word, so
Sure,
I'm a
no
little
problem. Yeah.
embarrassed. Sorry,
Okay.
audience. Let me repost it directly to you. There you go.
We posted in you posted in the chat box.
Yep,
Okay.
to the panelists.
Okay. Yeah. After alveolo, you might have excess of tissue. How would you handle that without losing attached gingiva?
I just suture down. So if I'm doing extractions and I have multiple extractions, before I do my flap and actually before I take the teeth out, I incise right through the papillas and get 2 clean margins. I then take the teeth out and I just suture that down. It will all bind down. We see that all the time with the veoplasties on all on fours when I'm taking 10, 12, 15, 20 millimeters of bone down sometimes. And we have excess tissue, it will heal down. I had done a technique where you drill through the mandible and then you suture almost like a litigation wire. The patient post-op was brutal. Okay, it looks awesome for the lectures, looks great for the pictures, ridiculous. Okay, so for what we do is we just let it heal down and it will be fine.
Thank you, doctor.
And then we have somebody, Dr. Boudayer. You wanted to ask a question live? Dr. Rima Boudayer?
Yeah.
Oh, maybe not.
No.
They changed their mind.
Change their mind. Okay, great. Yeah. Well, thanks for reposting that last question. Oh, we have one more that popped up here. Okay. If Dr. Boudayer, okay, if a patient doesn't like what, okay, let's see. It's hard to read this one. Patient doesn't like what unshaven. I can't read. It's not clear. This whole. Yeah, didn't come out right. Sorry. Yeah.
Oh, there's now.
Yeah. Can you read that one? I don't know. That's a tough one. So. Yeah, I don't understanding the question. It's just the spelling is not right. Here we go.
I think he's trying to say if a patient doesn't like what you have done, what do you do?
Oh, okay. Got you. Good.
That's
okay.
it.
I don't understand that question.
Yeah, I don't either. Yeah.
You know, if they don't, I mean, I tell people there's only a few things that are absolute in dentistry when I'm working with them. If you give me permission to take your tooth out, you're not getting your tooth back. You give me permission to drill an implant, that implant is staying, and I'm going to have to be motivated to remove that implant. You know, if a patient has anxiety during the procedure, I only orally sedate patients. I don't mess around with IV sedation. Okay. So if they are not able to stay in the procedure, raise your left hand, we'll stop, we'll stabilize them that day. One of my good friends or colleagues, the oral surgeons that are local here, they will dart you, put you out. You won't remember who you are, and we will do it that way. I'm busy enough that I don't worry about, you know, doing every implant in my office, and I don't want to do every implant in my office. It's a team approach. Do I place a lot? Absolutely. Do I work with my oral surgeons? Every day. And, you know, when I have complicated cases, and that's what my office focuses on, you know, when there's going to be a problem, I want multiple people on that ship if I think it's going to sink, right? There's a lot more people to bail water if you're going to have complications, right? So You have to decide that. So that's what I would say there.
Okay. Thank you. Thank you, Doctor, for that question also. So we have another one that popped up here.
I think this one's for Patrick. Could you please give us another webinar about the restoration part?
Yeah.
Well, I believe, about the restoration part, I believe Dr. Hallis does cover that part, you know, in the restoration of the implant secured overdentures. This one focused on the surgical aspect and
Part 4
right, there you go.
will be the restoration.
Good. Yeah.
So,
Stay tuned.
With that, I want to thank everybody for coming. Thank you for DSG and Sterngold for hosting, and I will see you guys next week.
Yep. Thank you, Dr. Hallis, and thank you, everybody, for coming and attending. And we appreciate it. Yep. And yeah, so next week, June 3rd is 7 p.m. Eastern time for part 3. Thank you so much, everybody. Have a great night.
Thank you very much. Thank you.